Okay. Box, please. This is condition of my glomerular apparatus. If you folks remember, glomerulus within the Bowman's capsule. Function is to filter the blood. My blood is filtering within the help of glomerulus and the Bowman's capsule. If somehow that filtering membrane is inflamed, most common cause of inflammation is immune mechanism. Normally during filtration, my plasma is filtered out. They will keep the red blood cells. All the form elements are not allowed to be filtered. Large proteins are not allowed to be filtered. But if my glomerulus is inflamed, they said, I can control. I'm permeable to everything. So they let form elements, like form element means RBC, WBC platelet, large proteins, everything is coming out in my urine because my glomerulus is inflamed because of what? Because of immune mechanism. Is it clear? That's called glomerulonephritis. Now, presentation of the patient. Number one, mostly these patients are mostly kids. Children are more susceptible, a more common disease is glomerulonephritis. So they present with hematuria with red blood cell cast. The urine become brown color, reddish tinge, and gives a signal that something is coming in the urine. And most likely it is the RBC. Now, we do have these patients, they do suffer from decreased glomerular filtration rate. Normal healthy adult, in normal healthy adult, we do have a GFR rate. How much? Anybody? What is the normal GFR rate? 90?
120. 120.
It's average is 125 ml per minute, and has to be normal GFR has, please remember, normal GFR has to be above 90 ml per minute. Okay, so in this patient, they do have reduced GFR. Highlight number 3. These are all important characteristics with patient with glomerulonephritis. Azotemia. Azotemia is a condition when nitrogenous waste products accumulate in my blood. Normally, nitrogen waste products are filtered out. Now, oliguria, low formation, reduced production of urine, oliguria. And also these patients, they do also have hypertension. We do check all kidney disease. Please remember, all kidney disease, hypertension is one of the important factors. We need to note hypertension also. Blood pressure. Disease, glomerulonephritis disease that provoke a proliferative inflammatory response of the endothelial cells, mesenchymal cells, mesenteric cells, or epithelial cells of the glomeruli. That lead to inflammatory process, lead to damage, the capillary wall. Number 2, permits red blood cells to escape in the urine, which was not allowed normally, and produces hemodynamic changes that decrease my GFR. Now, these are the types of proliferative type. Number 2 is basal membrane thickening, sclerosing type, fibrosis type. These are, we do see under microscope of the glomerulus of the kidney. Now, maybe there are diffuse changes, maybe focal, maybe segmental, or may involve mesenchymal cells. These, they do have the diagram in the textbook also of those changes. Now, put a star mark on this slide. Patient urine contains high protein. That's what's called proteinuria. Patient urine contains RBC, we call hematuria. Patient urine may have bacteria, may contain bacteria, we call pyuria. Patient urine volume is below normal, we call oliguria. Patient may have collection of fluid in the body tissues, we call edema. Patient may have hypertension. And the last one is azotemia. So all these are important features, characteristic of patient with glomerulonephritis. And also make a note over here, when these patients are losing protein in the proteinuria, that means I'm losing my protein in my urine. What happened to my blood? The protein in my blood goes down. Is it clear? We call hypoproteinemia. Hypoproteinemia, my blood protein is down because all the protein is coming out in my urine. Hypoproteinemia. Glomerulonephritis will result from which of the following? All of the above. There are different types. Glomerular disease, acute proliferative, rapidly progressive. Please highlight nephrotic syndrome. Again, nephrotic syndrome, children are more common. Nephrotic syndrome is more common in children. They do have proteinuria. They do suffer from hyperproteinemia. And also, by looking at those kids' face looks very puffy. Face is swollen. And that is because they are losing protein, they're giving edema of the face and the body, nephrotic syndrome. Please remember. And also important, whenever we suffer from chronic kidney disease, I said chronic kidney disease or chronic renal disease, patients are usually anemic. So, patient who is suffering from chronic kidney disease, they are pale looking. Why pale looking? They are anemic because the normal healthy kidney, that kidney produce hormone we call what? Anybody? Normal healthy kidney produce hormone. No, yes. That is called, make a note called erythropoietin. Erythropoietin, make a note and remember, normal healthy kidney could use erythropoietin. That's the hormone. And this erythropoietin is needed by red bone marrow. Red bone marrow need that erythropoietin for the production of RBC. So because my kidney is already damaged, I don't have erythropoietin, RBC count going down, I'm looking pale, anemia. Look at that connection. So most of the patients, those are suffering from chronic kidney disease, they are usually pale looking anemic. Now, because of my chronic kidney disease, I'm having, they said, now we need to start dialysis. After dialysis, kidney transplant, that's the last resort. Now, they start dialysis because I'm suffering from chronic kidney disease, my creatinine is way high, my urea is way high, blood urea high. Even if I do peritoneal dialysis, my anemia is not going to correct. Even I'm getting rid of the waste product, but anemia is not going to come back. We need, with peritoneal dialysis, anemia is not going to be correct. Everybody clear with that? Because my kidney is not producing hormone. Erythropoietin is not there. Everybody clear? Oh, I'm doing peritoneal dialysis, my mom will be fine, she'll be back. And the doctor said, she'll be fine. But fine in terms of kidney function, but not fine in terms of anemia. Please, everybody clear with that one? My RBC count, anemia is not going to be corrected, hematocrit is not going to be corrected because lack of erythropoietin. Okay. So from here, remember, nephrotic syndrome, we have acute glomerulonephritis, we have chronic glomerulonephritis, tubulointerstitial disorders, damage to the proximal loop of Henle, or proximal loop, or loop of Henle, or distal coronary tubule. Maybe acute tubular, renal tubular, highlight pyelonephritis, I mentioned earlier. And I mentioned about some drugs which are nephrotoxic drug, like non-steroidal anti-inflammatory drug. I mentioned about the Advil a couple of times. I mentioned about the gentamicin. Even though they have nephrotoxic effect, we need to be careful when prescribing. Sometimes we have to prescribe because of my report came that gentamicin is effective. Renal tubular acidosis, maybe proximal type, maybe distal type. Major group of renal neoplasm. Renal tumor may be benign or maybe acute or maybe malignant. Sometimes these tumors might cause obstruction of the blood flow. That's why we said earlier, if you remember, tumor might cause obstruction of the urine flow. In children, that's called embryonic kidney tumors occurring during childhood. It's called Wilms tumor. It's very painful. It's cancerous. It's a malignant tumor. Wilms tumor onset is 3 to 5 years. One or both kidneys. Wilms tumor, one mutation. So prognosis is not good. Makes maximum 5 years survival after surgery and chemotherapy and radiation. Very painful. We have in adult, we have renal cell carcinoma. Okay. Thirty. 34. Okay, chapter 34 is about the acute kidney injuries and chronic kidney disease. All topic is renal failure. Renal failure. Okay. How we define? A condition in which the kidney fails to remove metabolic end product or waste product from the blood and failure to regulate electrolyte, failure to regulate fluid, electrolyte, and pH balance of my extracellular fluid, that all this together, if they are there, then we call it kidney is failed. Kidney is gradually failing, it's renal failure. Now, the cause may be kidney disease itself, maybe systemic disease, or maybe urologic defect of non-renal origin. Maybe pre-renal, renal, or post-renal. Maybe before the kidney is healthy, something is wrong somewhere, we call pre-renal. Number two is my kidney is at fault. That's why it says kidney disease. Systemic disease, I'm suffering from hypertension, high blood pressure. I didn't notice, but still I'm having hypertension, and that in long run, that is damaging my kidney. Now, the third one over here said the urologic defect of non-renal origin, maybe the tube which carries urine from the kidney towards the bladder, or something is wrong in my urethra, somebody is compressing my urethra, maybe the prostate, a large prostate compressing, or some tumor in that area compressing my urethra. That leads to my kidney damage, renal failure. Now, prevention and early diagnosis of acute renal failure. Assessment measure to identify persons at risk of development of acute renal failure, those with pre-existing renal insufficiency and diabetes. There are these two things: diabetes mellitus, and hypertension. Please make a note. Diabetes mellitus and hypertension. Person suffering from diabetes mellitus for 20 years, 30 years, still on medication. In long run, this diabetes mellitus is damaging person's kidney. We call diabetic nephropathy. diabetic nephropathic. I was having diabetes and I'm being on insulin. So, but my sugar goes up and down and I keep damaging my kidney. So these are those with person with those with pre-existing renal insufficiency and diabetes mellitus. Elderly person, due to the effect of aging on renal reserve. Already I'm old. My kidney function is already going down. So we need to be careful that this person, if we don't take care of this person, the kidney will be more damaged. So types may be acute, may be chronic. Acute renal failure, which is abrupt, all and sudden, in onset. The good part of this acute is it is reversible. I can change it, provided if you recognize early and treat it appropriately. Two things. Acute, they found it, they detected early stage, and they treat it. I'm done. So that's the good part. Often it is reversible if, please remember, if they talk about if it is recognized early and treated appropriately, provided I need to follow the instructions of my doctor. Now, number two, chronic, the end result of irreparable damage to the kidney. Not possible. Too late. It develops slowly, usually over the course of numbers of years. Chronic renal failure, then we call end-stage renal disease. End-stage renal disease, during which they said you need to have dialysis. Dialysis not working, still everything going up. Then, if I'm lucky enough, I can get the kidney transplant. But you have to enroll it and wait in line. Now, pre-renal cases of acute renal failure, please highlight hypovolemia. Number two, decreased vascular filling. Number three, heart failure and cardiogenic causes. Number four is my decreased renal perfusion due to vasoactive mediators, drugs, or diagnostic agents. Sometimes we do use drugs for X-rays and CT scans and others. Those drugs sometimes react. Sometimes those call vasodilation that damages. And also with the hypovolemia, please write down dehydration. I'm working outside, profuse sweat, not drinking enough water, that might lead to acute renal failure. Dehydration is so important. Not all the time I have to have hypovolemia or low blood volume, but dehydration of my tissues also lead to one of the important causes is for acute renal failure. Look at the post-renal. Maybe there is a bilateral urethral obstruction. Or number two is bladder outlet obstruction. Bladder outlet obstruction, most common is by enlarged prostate. Because if you folks know that in male, we have three parts of the urethra: prostatic urethra, membranous urethra, penile urethra, penile or spongy urethra. So bladder outlet, most common is due to enlarged prostate when compressed by urethra. That lead to acute renal failure also. Congestive heart failure would be congestive heart failure dash cause of renal failure. It's a pre-renal, renal, or post-renal. Pre-renal, before the kidney, because the kidney is fine. And that is because my heart is enlarged. Congestive heart failure, my heart is enlarged, pumping mechanism of the heart is gradually failing. We call congestive heart failure, CHF, congestive heart failure. The pumping function of the heart is gradually decreasing, that lead to edema, that lead to kidney damage. So prenatal causes of acute kidney injury includes profound depletion of vascular volume, impaired perfusion due to the heart failure and cardiogenic shock, and decreased vascular filling because of increased vascular capacity. And with that, I said with the hypovolemia, add what? With hypovolemia, add what?
Hydration.
Dehydration. Very good. Okay. So, intrinsic or now the kidney cause, intrinsic or intrarenal causes of acute renal failure. My kidney itself is now at fault. Not pre-renal, not post-renal, now the renal. Maybe acute tubular necrosis, result from prolonged ischemia, exposure to nephrotoxic drugs. I mentioned that one. We need to be very careful. Drugs, metals, or organic solvents. Intratubular obstruction. Renal tubules becomes obstructed, resulting from hemoglobinuria, myoglobinuria. Everything's coming out. Myeloma, or a uric acid cast. They're damaging my renal tissue that lead to acute renal failure. They have phases. In the textbook, they mention about 4 phases. Over here, we have initiating phase, maintenance phase, recovery phase. In the textbook, they mention about the 4 phases. On page 1016, there are 4 phases of acute kidney damage, acute kidney injury. Okay. Now, the common causes for chronic kidney disease, please remember the first 2, hypertension and diabetes mellitus. Hypertension. I'm going to my doctor to check for normal checkup, but my doctor knows that I am a patient of diabetes mellitus. I am a patient of hypertension because that's what I'm getting medication from him, because he knows I'm suffering from diabetes mellitus. He knows I'm suffering from hypertension. Now, this time, I went to my doctor and doctor said, I'm having some difficulty in my urination. And also, I'm visiting the restroom often. Okay, so let me do one thing. Do some tests on you, and I need to find out how much your GFR is, glomerular filtration rate. Is it normal range or above normal or below normal? And also my serum we call serum creatinine levels. What is the peculiarity of specialty of serum creatinine? Does anybody have any idea? Serum creatinine. Serum creatinine is the chemical which is coming out with the help of kidneys. The kidney is the only organ in the body which can get rid of creatinine. Is it clear? First of all. So, if my kidney is not working, creatinine level goes high or low? Go high. Is that correct? So, the doctor, they said, I need to perform check your serum creatinine, I need to check your GFR, and also the blood sugars and others. So, the report came as doctor said, your GFR is below normal, maybe 40 ml per minute. Normally, you're supposed to have 90 and up. And your serum creatinine is above normal. Used to be between, serum creatinine to be between 1 to 2 milligrams. Normal serum creatinine, but it is way above normal. Urea is normal, above normal. So the doctor said, all these reports came because you have been suffering from diabetes mellitus and hypertension. That lead to your kidney condition. Look at that. Doctor connected his report, his presentation, that because why this GFR is way down, below normal, and serum creatinine way above normal. So doctor said, we need to take care of that. So, but doctor is making his comment on the basis of report. Is it clear? Okay. We mentioned about the polycystic kidney disease, obstruction of the urinary tract, glomerulonephritis, please remember, cancer, autoimmune disorders, diseases of the heart and lung, and the chronic use of pain medication. Sometimes we are addicted. I'm not feeling well, little headache, drink some water. Instead of drinking water, let me open the air. No, you need to take care of yourself. So chronic pain medication might in long run damage your kidney. Okay. So the stages of progression of chronic renal failure. Look at that. Gradually diminish renal reserve. Renal insufficiency. Kidney is not performing the job. They're not getting enough blood flow. As a result, everything is back up. Waste products are building up. Now I'm suffering from renal failure. Please highlight the last condition over here. We call end-stage renal disease. End-stage renal disease. Now, the doctor said you are in end-stage renal disease. Now we need to take care of it. Dialysis. Is it clear? Dialysis. Now, when patients are in end-stage renal disease, they need to follow a strict regime of the diet. Very important, diet especially. He or she can have carbohydrate, they need to he or she can have the fat, carbohydrate, fat, but they need to cut down protein. Protein is restricted. Not only protein, they need to cut down their fluid also. Daily fluid requirement. Daily fluid requirement for me, it is almost 2000 liters, 2000 ml. So patient who is suffering from end-stage renal disease, the fluid volume need to be restricted, almost 500 ml to 1 liter per day. That's very important. So the patient should be on diet restriction. We call renal diet. Like diabetes mellitus has dietary restriction, is that correct? Patient with diabetes mellitus, they put on dietary restriction. They need to maintain that one. They have to live with that. Similarly, patient with end-stage kidney disease, they should have follow the renal, we call renal diet, which is restricted in protein, restricted salt, potassium, and also fluid. Okay. This is about the GFR we mentioned already, PowerPoint. Mild, moderate, and severe. We said normal has to be above 90, please remember. So the kidney failure when the GFR is below 15 ml per liter, per minute, sorry. Normal, we said, normal healthy adult, according to the textbook over here, above 90. And in anatomy, because that is almost, a normal healthy adult is almost 125 ml per minute, based on your blood supply. Okay. Uh, 15. Okay. Now, the clinical manifestations of chronic renal failure. Look at that one. Everything is piling up. Accumulation of nitrogenous waste. Accumulation of nitrogenous waste that lead to azotemia. That lead to, please remember, I mentioned earlier, azotemia, because my nitrogenous waste products are building up in my blood. Number two, alteration in water, electrolyte, and acid-base balance that lead to edema. Minerals and skeletal disorders, anemia and coagulation disorders. Chronic renal failure, they do suffer from, please highlight, I mentioned that one, anemia. Why? Because the kidney is already diseased, erythropoietin is not there, red bone marrow is not getting the erythropoietin for RBC production. Hypertension and alteration in cardiovascular function. If you folks remember, kidney performs important function we call renin-angiotensin mechanism. Renin-angiotensin. When blood pressure is low, kidney helps to raise. When blood pressure is high, kidney helps to lower the blood pressure. So patients who suffer from chronic, they do suffer from. So hypertension can lead to chronic renal failure. Chronic renal failure can lead to hypertension, vice versa. Please remember. Okay, we do have gastrointestinal disorders, neurologic complications, disorders of the skin, and immunologic disorders. How to take care? Treatment during renal insufficiency. The stages of renal failure depends. Using measures to retard deterioration of the renal function and assist the body in managing the effect of impaired function. We need to take care. Look at the smoking. They put in the last one. They should be in the first one. So treatment, urinary tract infection. If we have UTI, the person suffering from UTI, that is need to taken care. Avoid medication with damaging potential nephrotoxic drug. We need to have good proper history of medication history is important. Controlling blood pressure, controlling blood sugar in person with diabetes, and stopping smoking. Target populations comprise person with chronic renal failure, person with person with chronic renal insufficiency, person with renal failure treated with hemodialysis. Now the question of hemodialysis is very important. Person with renal failure being treated with peritoneal dialysis. Now, peritoneal dialysis, this can be done at home. Please listen carefully. This can be done at home. Patient treated they go under training how to take care of that peritoneal dialysis. Patient is informed how you're going to operate, how you're going to use that one, how you will change the dialysis bag. If this patient is said, I have a hard time, I can get up at night and change the my dialysis bag. If I'm giving history to my nurse that I can get up at night to change that bag. It's a nurse responsibility. It's a nurse job to talk to the nephrologist. The patient said this one. The patient, nurse heard that one. You just cannot ignore that. That's very important. Patient need to get up at night, change the bag. Is it clear? Now, and also the fluid which is coming back during dialysis, patient need to know what's going on. If the dialysis fluid is cloudy, I said cloudy, that indicates something wrong in my peritoneum. I'm suffering from peritonitis. If the fluid is coming back, that fluid is not clear, it's a little cloudy, the patient should report to the nurse, and also nurse should inform the patient that if you see the fluid is cloudy, don't stay at home, report, because something is wrong over here. Maybe the patient is suffering from what? Peritonitis. That needs to be taken care right away. And also I said, they start my peritoneal dialysis, doctor. Can I get my anemia improved? No, anemia is not going to improve with peritoneal dialysis. Dialysis is helping to flush out your waste product. Please remember, anemia you can correct with dialysis. Hematocrit level you cannot correct with dialysis. Clear? So that is then the renal transplant. If you're lucky, so go for kidney transplant. Okay, so factors determining the manifestation of renal failure, extent of renal function that is present, how much is left, how much healthy kidney is left, coexisting disease conditions, my blood pressure, my heart condition, my diabetes. Number 3, the type of renal replacement therapy that the person is receiving. Now, disorders of water, electrolyte, and acid balance because my kidney is not working. Look at that one. Sodium and water balance. The kidney function in the regulation of extracellular fluid volume. So we need to put restriction on those things. Potassium. Approximately 90% potassium excretion is through the kidney. If the kidney, I'm suffering from chronic kidney disease, my potassium needs to be restricted, my sodium need to be restricted, my water need to be restricted. And acid-base balance. The kidney normally regulates the blood pH by eliminating hydrogen ions produced in metabolic process and regenerating bicarbonate. So we need to watch, we need to be careful about the acid-base balance of the kidney. Otherwise, if we don't maintain that one, that might lead to stone formation again. Anemia, coagulopathy, hypertension, heart disease, pericarditis, by cardiovascular, chronic kidney disease, altered drug metabolism kidney disease. Chronic kidney disease and its treatment can interfere with the absorption, distribution, and elimination of the drugs. So we need to know altered drug absorption, antacids, sometimes those antacids contains calcium. Altered metabolism results in less protein-bound drugs and increased intermediates of drug metabolism. These are all important. So it's we're not only suffering from kidney, we have doctor need to know all those parameters which the patient needs, whether that is okay for this patient at this amount of damage or not. Alteration in the dosage may be required. I'm okay with 300 milligram, 325 milligram of aspirin. But this patient who is suffering from chronic kidney disease, that aspirin is not okay, that dosage aspirin is not okay. For him, it is nephrotoxic. For me, it's okay. Is it clear? So we need to be very careful about the dosage. Even I said about the antibiotic gentamicin. Everybody's okay with gentamicin? I said that one a couple of times. Gentamicin is one of effective antibiotic, but we need to be careful when the patient is suffering from kidney disease. Sometimes the report says it's effective because the organism came in my report, the organism said patient needs gentamicin. My hands are tied up. Now, how I can treat? Because the patient weight, body surface area, based on that one, if it says, suppose it says 1 milligram, I cannot go with 1 milligram. It is that 1 milligram for normal healthy person. But patient is already suffering from kidney disease. I need to reduce the dosage of gentamicin and see how it is affected. Okay. We do have aminoglycosides, gentamicin. I said about non-steroidal anti-inflammatory drugs. Okay. Which of the following alteration may affect the drug efficacy in patients with chronic kidney disease? Loss of potassium, alteration of pH, loss of albumin, increased calcium. Because albumin, I'm losing because my kidney is unable to retain those albumin. Albumin is a plasma protein which is larger in size. Normally during glomerular filtration, this albumin is not allowed. I'm losing this albumin, and that's why I said patients with chronic kidney disease, they do also suffer from hypoproteinemia. Hypoproteinemia. That is protein is over here. Albumin is one of the proteins. Now, so loss of albumin will result in altered drug metabolism via the increased intermediate, because this albumin not only maintains the osmotic pressure, but this albumin also helps in the transportation of various types of drugs. Traces of medication are transported in the blood with the help of albumin. Albumin is not there. So who is going to transport it? So we need to be careful with that one also. Okay. Hemodialysis, peritoneal dialysis, and transplantation. Dietary restriction, renal diet. Patient can have carbohydrate, patient can have fat, but not the protein. Not the protein. Reduce the amount of potassium, reduce the amount of sodium, reduce the amount of fluid intake. Is it clear? Yes or no? I can go repeat. So it says dietary management with patient with kidney failure or renal failure. Patient need to be restricted on protein diet. Patient can have normal carbohydrate diet, calories in terms of, and normal fat. No restriction on fat and carbohydrate. Potassium need to be restricted, sodium need to be restricted, fluid need to be restricted. Okay. Now, chronic kidney disease in children causes maybe congenital malformations, maybe inherited disorders, acquired disease, or metabolic syndrome. Because of the kidney disease, I'm suffering from severe growth impairment, developmental delay in my sexual maturation, delay in my bone abnormalities development of psychosocial problem. In elderly, normal decrease in the GFR with age, increased detrimental effect of nephrotoxic drug. Greater incidence of cerebrovascular, cardiovascular, and skeletal system effect. Okay, folks, I mentioned about the peritoneal dialysis. Please remember what we discussed with this scenario also. It was not in the PowerPoint, but I discussed. So let's have a break. Returning time, I'm getting 11:30. 11:30, we'll come back and take care of chapter 35. Folks on Zoom, 11:35 is the returning time. 11:30. 11:30 is returning time.